It's my honor to introduce the next presenter, which will be Dr. James O'Neill. And I had the privilege of meeting Dr. O'Neill at about 1985, 1986. I was asked to go pick up the visiting professor in my car, which was probably not a good move. I owned a small Porsche at the time, and that probably wasn't very thoughtful on my part, but I had a flat tire on the way, was extraordinarily late to pick up a really already world famous professor. But one of the things that I learned from Dr. O'Neill, who is probably an icon in his own right, was about 2 weeks later, I got a handwritten letter in the mail thanking me for picking him up. He didn't even say the word late in there, and it's something that I've actually taken with me. And for any of my people that are here, I have a stack of thank you cards on the top of my desk that I write as a lesson that I actually learned from you many years earlier. So I'd like to welcome Dr. O'Neill to the stage, who will present Dr. Basil Pruitt.
Thank you, Steve. I never held it against you. These two videos are really a testimony to the military. And the value is to highlight the advances in medicine, and particularly surgery, which have come about primarily through the efforts of the military and the thousands of surgeons who have participated in conflicts over many, many years. Now, these videos will be on, and several are already on, the college website for your enjoyment. I'd like to have you take one message from this video about Dr. Basil A. Pruitt, Jr. First of all, I've known him for 52 years and worked with him at the beginning of my academic career and the beginning of his. And so I have a special perspective on his background. The three pillars of surgery are exemplary patient care, you'll see that, outstanding educational effort and output, and you'll see that, but most importantly, the thing I'd like to have you take away from seeing this video and hearing him speak in his words is a characterization of the values of surgery. And in particular, in his case, the output of research that has transformed a part of our surgical armamentarium. He certainly has left the field of burn and trauma surgery far better than he encountered it. And I think it's important for you to be able to appreciate his philosophical background as he expresses himself. So I hope you enjoy this video very much. Thank you. My name is Dr. James O'Neill, and my purpose today is to introduce you to one of the great people in American surgery. It is a pleasure and a privilege for me to introduce Dr. Basil A. Pruitt as a true icon in American surgery. I have known and worked with Dr. Pruitt since 1965, when I served with him in the U.S. Army Institute for Surgical Research at Brooke Army Medical Center, Fort Sam Houston, Texas. Dr. Pruitt was born August 21st, 1930, in Nyack, New York. Dr. Pruitt's father was a stockbroker in New York City, but when the Depression hit, he had to change careers. His father then started working for the Skelly Oil Company in Quincy, Kansas, where Basil's grandparents lived. Dr. Pruitt's grandmother played a significant part in his upbringing. After several moves, the family settled in Dallas, Texas, where Dr. Pruitt graduated from a local high school. He did well enough to be accepted to Harvard College, from which he graduated in geology in 1953. At that point, he found medicine more interesting than geology and entered the Tufts University School of Medicine. Halfway through, he married Molly Gibson and they eventually had 3 children. Dr. Pruitt graduated from Tufts in 1957, and after that, he entered the surgical residency program at the Boston City Hospital under Dr. C. Gardner Child. However, his residency was interrupted when he was inducted into the United States Army. Fortuitously, he was assigned to the Army Surgical Research Unit and Burn Center at Brooke Army Medical Center in Texas, where he also completed his general surgery residency in 1964. For the next 3 years, he served at the famous Burn Study Center at Brooke. This provided Dr. Pruitt with valuable experience in aeromedical evacuation. In subsequent years, he and his colleagues performed the very first airborne ICU flights for patients being evacuated from Vietnam to the continental United States. Dr. Pruitt was also interested in research during his time at Brooke. From 1965 through 67, when I worked with Dr. Pruitt, together with John Moncrief, Robert Lindbergh, and colleagues, Dr. Pruitt performed landmark clinical research with a new topical antibacterial agent, sulfamylan. Dr. Pruitt served as head of the burn study division at this unit until 1966, when he became the overall clinical chief. In the years 1967-68, Dr. Pruitt was appointed Chief of Professional Services at the 12th Evacuation Hospital in Cu Chi, Vietnam. He was not just an administrative commander, but was an active surgeon working with his team, while they additionally coordinated clinical research studies. At the end of his assignment in Vietnam, Dr. Pruitt received the Presidential Distinguished Service Medal for outstanding service during wartime. In 1968, Dr. Pruitt returned to the Army Surgical Research Unit in San Antonio. He remained in that position for 27 years. He elevated the reputation of this unit that was visited by many U.S. presidents and foreign visitors to be the preeminent burn center in the world. Along the way, he was promoted to full colonel. Then at the Institute for Surgical Research, Dr. Pruitt developed what was to become known as, in quotes, the burn team. He made regular rounds twice daily with the team to review clinical progress and research protocols. Perhaps more importantly, Dr. Pruitt and his colleagues used their clinical experience to answer research questions such as appropriate approaches to inhalation injury, infection, wound care, and various aspects of metabolism. Several animal models were developed to investigate pathophysiology and treatment approaches. The unit also became known as a place where every patient was treated as if they would survive. Dr. Pruitt also had a research team in the laboratory, including Dr. Robert Lindbergh, Dick Mason, Dr. Pruitt's long-term collaborator, and others. One of the most important observations they made related to the care of burn wound sepsis, developing a famous animal model and experiments that showed that mortality was directly related to the extent of burn. It was also a way to test various topical antibacterial agents. Furthermore, Dr. Pruitt developed collaborations with universities around the world, including Japan, China, and of course the United States, which expanded the influence of the ISR. In 1995, after 27 years at the unit, Colonel Pruitt retired and was presented with the post and unit flags, but he did not rest there. He joined the faculty at the University of Texas San Antonio School of Medicine as professor of surgery. He also became the long-term editor of the Journal of Trauma, which he also elevated to be world-class. However, he would count his greatest accomplishments to be his marriage to Molly of over 50 years and his wonderful family. Dr. Pruitt is arguably one of the leading surgeon scientists of our time. He received numerous medals and awards, including the Tanner Vanderput Burn Award, the Scientific Medallion of the American Surgical Association, and the King Faisal International Prize for contributions to the care of burns and trauma. Finally, Dr. Pruitt's mentees populate burn trauma units and burn research units throughout the world. His accomplishments have not only had military significance, but they have made a difference for all mankind. Dr. Pruitt continues to be active, and there is hardly a surgical interface that Dr. Pruitt has not influenced. So now let us take a bit of time to enjoy his perspectives.
I decided to change careers because I tired of classifying Ordovician trilobites and decided that there might be more to life, and I applied to medical school. As I think happens to a lot of medical students, I wanted to be whatever rotation I was on for a while. And then I had a critical rotation on the surgical service at the Boston City Hospital with Gardner Child. Dr. Child was an impressive surgeon who had been on the staff at the New York hospital, came to Tufts as the chief of surgery, and I came to think that he really hung the surgical moon. Dr. Child had a special interest in the portal circulation and in liver disease that altered that, and would round with us once a week. He insisted that we have a shirt, coat, and a tie on. Each of the female patients at the Boston City Hospital was introduced as a lady. Dr. Child also had a great respect for the patients and taught us in many ways what it was to be a surgeon and a medical professional. Also, in terms of the interest in research. The importance of mentors can't be overemphasized in terms of my career, and is an important aspect of every physician's, certainly every academic physician's. In my case, my early surgical mentors were Gardner Child and his assistant, Arthur Donovan, who became chair at the University of Southern California. Other mentors would be Dr. Moncrief, both as a military leader and as an investigator. Dr. Edward Vogel, who was a very effective military administrator. Later on, Dr. Mason was a scientific mentor. The direction of my career into a strong research component and primary focus on burns and other forms of trauma, but principally burns, had to do with my early observation that a significant burn injury affects every organ system in the body. So there's no end of fruitful research topics. And my early experience with the development of effective topical antimicrobial therapy convinced me that the most efficient and effective way of conducting research was by integrating clinical and laboratory activities. And that was in an early embryonic form at the Burn Center when I arrived there in 1959 with an assigned microbiologist. But the new thing then was that we had a pathologist assigned, and prior to that time, every burn patient that died was signed out by the regular hospital pathologist as died of burns, and that's not very helpful. But having a dedicated pathologist, it was identified that invasive burn wound sepsis was the cause of death of 60% of the patients that died at the burn center. And then from there, we took that problem to the laboratory, developed a model that simulated the clinical condition, showed that there were ways to prevent this progressive infection through the burn wound in the model and bring that information back to the clinic. So it's this clinical laboratory back to the clinic, back to the lab iteration that is so effective and can have the greatest chance of developing useful intervention, I think. The development of effective topical antimicrobial therapy is an interesting story. The history of infection in severely injured burn patients recapitulates the change in infecting flora throughout medicine and surgery. Originally, before the day of penicillin, it was the beta hemolytic strep was the most common cause of fatal infection. With the development of penicillin, it became staphylococcus as the most prominent, and with the development of some of the semi-synthetic penicillins, it became the gram-negative organisms. But that knowledge was late in coming. These patients would do well for several weeks, and then the wounds would disintegrate, and they would have what we now recognize as systemic sepsis and expire. Dr. Irving Rabin, he and his successors identified the pathogenesis of invasive infection, developed a murine model, identified the fact that topical sulfa compounds, the most effective being sulfamylon, could prevent this progression of microbial invasion and turn a uniformly fatal model to uniformly surviving model. And that information was brought back to the clinic. The first application was a young patient, and he was septic, and John Duckett recognized this, went to the lab and got some of the sulfamylon. You couldn't do that today, but it was in its final formulation, but hadn't been approved by anybody. Brought it back, put it on the patient, and he had a almost instantaneous recovery from the septic state. The patient survived, was excised, later excised and grafted, and has had a very successful life. I think the burn patient is the universal trauma model. As is true for any physiologic problem, a solution of that problem invariably reveals other problems that were previously inapparent. So with the control of invasive burn wound infection, it became obvious that inhalation injury was a very important comorbid factor in burn patients. So attention was directed to inhalation injury in terms of the pathogenesis and the pathophysiology. And with that information, we could identify the fact that high frequency interrupted flow positive pressure ventilation could restore balance between the airflow and the blood flow and had a significant effect on survival in these patients. In addition to that, of course, we had studies in which you participated on the pathogenesis and treatment of acute stress ulcers in burn patients. We had studies of renal function in burn patients, and we studied the metabolic response, which was another revolutionary change. Mentoring is a very important function of an academic surgeon in passing along accumulated information and allowing them to build upon what you may have accomplished. I would suggest that every young surgeon identify a problem, a clinically important problem that interests him. Then position oneself so that he can care for a number of those patients. Try to identify what the pathogenesis of the disease process is, and take that to the laboratory to develop an animal model that simulates that, and then organize a collaborative team of other clinicians, but equally and sometimes more importantly, laboratorians that have the expertise and the capability of current laboratory testing to address that problem in the model, hopefully develop a solution and bring it back to the clinic. Along the way, it would be wise, I advise many of the younger people, when they identify this problem, write a review of it. And that immediately establishes them as at least a minor authority. One of the great satisfactions that I've had is that I've had almost a second career as a medical editor. When I retired from the Army, I became the editor-in-chief of the Journal of Trauma and Critical Care Surgery. This was a challenge because the criteria for writing in the trauma realm was not all that rigorous. I didn't read every manuscript, but I read every review. And I learned a couple of things. Number one is that important medical information is not perishable, and it should be presented in its optimum form. So it might take a couple of revisions before you were happy with this, with the quality of the report. The second principle is that the editor needs to guard the editorial pages to ensure that it's the highest quality information that is being disseminated.
Can we have the room lights up?
It's been an amazing career that I've had in the military and at the University of Texas Health Science Center. And it was probably in significant part due to a temporal juxtaposition of a couple of factors. That is, the Berry Plan subjected physicians to draftability until age 35, long after anyone else stopped being drafted. So I would have calls from Franny Moore and Jonathan Rhodes and Bill Altmaier and others saying they had a resident that was finishing the program and was interested in an academic career and thought they could contribute to our activities at the Burn Center. And so that ensured a supply of really well-qualified, intensively active, ambitious surgeons. The other factor that I can attribute success to was the involvement of the laboratory scientists. Our team consisted of biochemists, physiologists, nurses, physical therapists, occupational therapists, microbiologists, and a host of medical specialists, pulmonologists, nephrologists, all of that. We had Saturday morning rounds. Those, of course, are an anachronism now. They became an anachronism the week I retired, but But it did get the laboratory people talking to the clinicians who identified the problem and helped them develop the laboratory studies that would address that problem, characterize the pathogenesis, and hopefully develop a solution like we did to improve fluid therapy, treatment of inhalation injury, revolutionized metabolic support, and the whole concept of what post-injury hypermetabolism was. So it's been a great career, and of course the big reward is the improvement to the patient. The second reward is you just relish the success of all the colleagues with whom you've worked. And that's been a real satisfaction to see our 13 chairs of surgery, 2 of urology, 2 of pediatric surgery, 4 in anesthesiology, a couple chairs of medicine, and then 8 out of 9 Japanese fellows, 3 of them have become chairs. So this is just a great satisfaction. It might not ever be possible again because there's no longer a draft, and the laboratory integration has sort of fallen apart, but that I think could be restored. But it's been a great experience, and I'd like to thank the college for this recognition, and particularly Dr. O'Neill. We shared an office at the Burns Center. He is a world-renowned pediatric surgeon. But when he was the president of the Southern Surgical, I actually felt compelled to stand up and say that he was a closet burn doctor masquerading as a pediatric surgeon.
Nice.
Thank you.
Don.
I've known Basil only for a short time, but I know that I've got to get my words in before he, while he pauses. But part of the success, again, of the Surgical History Group and the success of the history effort of the meeting is because of Basil's leadership as program chair. And I think that today's panel on the president, surgical care of the presidents is evidence of that. But I can always count on Basil's support and also his candor, because if he disagrees with something, I know it's going to be good advice. So thank you again, Basil.
Before we take our next question, just want to remind the Icon series will continue tomorrow at 11:30 in this room, and tomorrow's Icon presentations will be Seymour Schwartz and Patricia Newman. So right here in this room at 11:30, we'll continue this this story. So we'll take a question from the first microphone. Comment.
Juan Asensio, I've met the professor, which is the way all trauma surgeons address Basil, many years ago as a fellow at Parkland with one of my professors, Charlie Baxter. I can tell you that when he appointed you to the editorial board of the Journal of Trauma, that ran and still runs as a tight ship. Although he says he didn't read any manuscript, I can call upon many of our colleagues, from Don Trenke to Gene Moore to Ken Maddox to Bill Schiaffi. We believe that he read everything. If you got a manuscript back, and the one thing that a lot of people may or may not know is that Basil is a consummate writer. You knew how all the reviews came, and he will tell you he learned that at Harvard. And so he was very influential. When that editorial board would meet, and even now that he is, emeritus, everybody pretty much stands at attention. He has been very influential to many people. I can tell you that when Bill Schiaffi, one of his very proud mentees, and I put together an atlas of trauma surgery, we would meet, and it was very difficult, and we would always say, what would Basil say? Are we writing properly? My favorite story about Basil, and been very privileged to be at many international meetings with him. We were in Turkey as visiting professors, and we had boarded the Turkish airlines, sitting there first class, and somehow or another, this military come to all of a sudden asking for who was Dr. Pruitt. So he looks at me, and I'm thinking, oh my God, a Turkish person. So he hands me his passport, and he walks out. I try to run, and one of my former partners, Dimitriadis, was very much looking around, afraid, and they stopped me. And so Basil marches off, and I'm thinking about that movie, you know, and the reason why they pulled him off is that he has this medal, you know, in his shoes, and eventually he came back, and we were all very upset, and he came back and he says, now you can give me my passport back. If you've ever flown with him or ever been with him any time, not only you see a source of advice and inspiration, and I can tell you he's very proud, and he still serves, and is very well connected with his alma mater at Harvard. So Basil, I hope you're around for many, many more years, and we will try to continue to write as well. You've been a mentor to many of us, and as I said, for Norman and for you, God bless you. Thank you very much for what you've done.
Well, thank you, Juan. I certainly share all of those hopes.
Hi, Fred Grover. I'm from University of Colorado, but I was at the University of Texas in San Antonio for a number of years. So I can come up as someone who wasn't directly trained by Basil except by observation. And having trained in Denver and seeing Tom Starzl going from the laboratory to the clinic back and forth, you did that absolutely the same way, in superb excellence that Tom did in the burn era, and brought up during my training and afterwards the science of burn care through your careful research and your patient care, but also your leadership skills. You don't take a Brick Army hospital and carve out you came in to a burn center that was carved out already there, but you took it to the next level with your leadership skills. And then a third thing I'd like to mention is your effect on the University of Texas and our conferences and that type of thing. When you would come to a surgery conference, it was always notable, and you all in the room here know Basil can ask pretty pointed questions. And if somebody doesn't really know what they're talking about, he can kind of maybe not so gently point that out. So it took the level of discussion up and made it a much more academic environment. So I appreciate all those things, and observing you, your leadership skills over the years, the way you've been able, as you've grown in your career, to change the directions of your career and continue to make contributions well into your 80s, and whatever you are now, you're still making those contributions as editor and so forth. And then one thing that hasn't been mentioned is Molly and your wonderful family, your wonderful daughter and your 2 sons. And you obviously are very proud of them as well. So my wife Carol and I congratulate you on your continued success and your exemplary, your example that you set for all of us in medicine. Thank you.
Well, thank you very much. I certainly give full credit to my wife Molly for having superintended all the children's activities when I was either at the hospital or off traveling. And all 3 of the children have been hard workers. I think we set a good example that way. One is a surgeon at Duke and Merck. The younger one just became a professor of radiology at Parkland, and our daughter is a partner. Her expertise is in broker-dealer regulations for securities law, whatever that is, I'm not sure.
From the first microphone.
My name's Sid Brevard. I'm a professor of surgery at the University of South Alabama. December of 1988, I was on your service as a PGY2. Matter of fact, we operated on Christmas morning with an excision grafting. I did not have a PGY3 position, and my career was about to end. After my time with you, I got a call from LSU, Chief of Surgery, Burn Surgery, Ed Deitch offered me an interview and eventually a job. My career would have ended without your help. So thank you, sir.
Well, as sort of final comments, let me say that I fully recognize that if you come upon a turtle on the top of a fence post, you realize he's had a lot of help. And I've had a lot of help, both in the Army and now for the last almost 2 years at the University of Texas Health Science Center. And it's the colleagues with whom I've had the privilege to work at both places that have made all of these things possible and have certainly enriched my professional and personal life. And I'd like to particularly recognize Jim O'Neill, who was such a kind interviewer and has been a close friend for all these many years. I'd like to thank the committee for having designated me an icon, Dr. Richards, and the College of Surgeons for the designation as well. Thank you.
I think there was one more person who wanted to make a comment. You get one more shot at the microphone. Yeah. Did you want to make a comment? Because we're saving these forever, so we didn't want to cut you off. So you get to be the final word.
Justin Barr, resident at Duke University, and my comments are really for both icons, Dr. Rich and Dr. Pruitt. I met him about 5 years ago as a medical student, interested in surgery, interested in surgical history, and they've just been incredibly giving of their time, their effort, their resources. And both men have talked about the importance of mentorship, and I just want to thank both of them for the time and the mentorship that they provided me in my young career. So thank you both.
Thank you so much.
Thank you. I want to thank everyone that attended today's session. This is truly a remarkable 2 series of videos. We have 2 more excellent videos tomorrow at 11:30. But also, I want to encourage you to put forth your comments to the American College of Surgeons about the importance of having these videos and what the session meant to you today, so that we can continue this series as we embark on next year's icons. But again, thank you, Dr. Rich and Dr. Pruitt, for your wonderful contributions and for being our icons this year.